Hello, and thank you for joining us for today's session. This webinar is part of the Lutheran Services in America Strength and Service series, where we invite a wide range of speakers to share emerging trends, policies, and perspectives. Today, I'm honored to welcome Dr. Dora Hughes. She serves as Chief Medical Officer at the CMS Innovation Center, Centers for Medicare and Medicaid Services. As the Chief Medical Officer, one of Dr. Hughes's many responsibilities is to lead the center's work on health equity, population health, and addressing the social determinant of health gaps, the social risk factors and unmet social needs that directly impact health outcomes. Today, Dr. Hughes will share how CMS is working to further advance health equity and improve health outcomes for rural and underserved communities, and the policies, practices, and partnerships that are required to move this work forward. We want this to be an interactive session, so please feel free to enter your questions in the chat box at any point. And now I'd like to turn it over to Dr. Hughes.
Thank you so much. And again, thank you so much for inviting me to join you today. I'm going to share my screen, and please let me know, and please confirm that thumbs up that you can see these slides. Okay, excellent. Okay. I'm not able to see the chat very easily. So again, if you put your questions in the chat, we will certainly have time to discuss the questions, comments that you have at the end of our presentation today. As Alicia mentioned, I'm going to talk about our efforts to advance equity through the CMS Innovation Center. I thought I would start out, for those of you that are not as familiar with the CMS Innovation Center, we were created as part of the Affordable Care Act in 2010. And we were charged by statute to test models. We call models what some people might call demonstrations or large research initiatives. We call them models. Our charge was to test models that can improve the quality of care or reduce the cost of care. Ideally both, but at least one of the two prongs have to be met. And through our models, we have tackled a number of different settings, whether it's urban or rural, a number of different provider types, primary care, specialists, EMT in one model, community-based providers. We have tested models targeting certain disease conditions such as kidney disease or cancer, diabetes. It's also important that we are looking across all of our different payer lines here at CMS, including traditional Medicare, fee-for-service, Medicare Advantage, Part D, Medicaid, and I like to tease my colleagues in the marketplace that we're coming after you next. And so we, but do think it's very important that we test all the different payer lines for which our beneficiaries, through which our beneficiaries are receiving care. Since our inception, we think that we've had a pretty broad impact and reach. In one 2-year study, we tried to quantify our reach, and we had touched over 28 million beneficiaries during this 2-year period, and over 500,000 providers or provider types were participating in some fashion in our models. Our models have spanned all 50 states and the territories, DC, Puerto Rico, and we think, again, that we've had considerable reach since our inception. Now, in 2020, 2021, towards the end of our first 10 years, which also coincided with the change in administration and different direction, it made sense to take a step back and think, what have we learned over our first 10 years? And what do we want our vision to be for the next 10 years? And so as part of that, a little over a year ago, we released our 2030 vision. And a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And within this vision statement, we have 5 strategic objectives. The first objective is driving accountable care. We want 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in relationships defined by accountability for the quality of care and the total cost of care. Our second pillar focuses on advancing health equity, and I'm going to dive a little bit deeper in that in the next set of slides. Our third one is supporting innovation. what are the tools, what is the technology, what is the data, what are the learning systems that will help providers, those participating in our models, be successful. The fourth strategic objective is addressing affordability. And we have initially been thinking about that at a high level. How do we drive down waste? How do we reduce duplicative services? More like the systems-wide costs. But in October, as you may be aware, we were charged by the president's executive order to think about how can we address high drug prices. And a couple of weeks ago, we released a report out on several proposals that we will pursue that can address the high costs of drugs for our beneficiaries. And so we are moving from the high level systems wide costs to thinking about what are the costs specifically for our beneficiaries in terms of their direct costs, co-pays, and whatnot. And then the final area, really important, is partnership. And I would say, I think many of my colleagues would agree that in our first 10 years of operation, we were quite fortunate to have an amazing cadre of providers, institutions, healthcare settings, organizations to be part of our network, if you will. But we're really trying to move, expand upon this network to bring in more patient advocacy, beneficiary advocacy organizations, to think about more safety net providers, institutions that can inform our work on health equity in addition to other areas. Just really trying to be mindful that of all the different types of stakeholders that care about the work that we do, we want to make sure that they are represented and providing input throughout the lifespan of our models. And so the partnership part is especially key. So if we think about advancing health equity, just to dive a little deeper, this is our second strategic objective. And I would note that CMS-wide released a strategy that was released after we had released our strategy. But in the CMS-wide strategy, advancing health equity is the first pillar. And there's also a framework on health equity, and there's not surprisingly considerable alignment between the two, both the CMS strategy as well as the CMS health equity strategy and the framework, very much aligned. But for us, we had proposed focus on four different areas, four different topics. And the first very generally, as we develop new models, or if we modify existing models that have at least 3 years left in the lifespan, how do we embed health equity? What are the care delivery requirements? Who's on the care team? What are some of the financial considerations? And I just don't mean funding levels, but again, what's the timing of the payment? Is it upfront or is it throughout? What's the level of payment? What's the structure of providing additional payment? Is it through benchmark adjustments or cooperative agreements? So really thinking through it, all the different aspects of our model, how can we better embed health equity? The second area of focus is really increasing the number of beneficiaries from diverse populations. When we look back at our first 10 years of models, the beneficiaries served through our models tended to be higher income, more affluent, and also white. And so we wanted to make sure we're serving the full panoply of populations that are receiving care through our programs here at CMS. And as part of our strategy, we think it could be especially useful if we include more safety net providers and safety net institutions. And by that, of course, I mean federally qualified health centers or critical access hospitals, or if we think about some of providers that have served large numbers of Medicare Medicaid beneficiaries, we want to make sure again that we're including more safety net providers and organizations in our models. The third area focuses on evaluation. It's always a bit ho-hum, but we realized again, we weren't always asking the question, what is the impact on health equity that our models are having? And that's especially critical, not only for evaluation, how well have we succeeded, but that certainly our findings help to inform future models, future efforts down the line. And the fifth area, which is the critical linchpin across all these different areas, is how are we strengthening data collection and reporting across all the various socio-demographic groups. And so that's beyond race and ethnicity. We're also thinking about language, geographic areas. We're certainly thinking about disability, sexual orientation, gender identity, being mindful across all of the various demographic groups that we serve. Also, we are trying to think more about how can we collect data on social needs, health-related social needs. And that's another area where we are trying to modify not only our learning systems, but our data collection. How can we what are some of the tools we can create on our end that can facilitate collection, both for socio-demographic data, but also health-related social needs data as well. I'm going to move to the next slide. I think we are certainly trying to take a life cycle approach to our models as we think about opportunities to embed health equity. I mentioned even at the outset, how do we embed health equity, starting with ideation? Does this model even have relevance to disparity populations? And as example, we're thinking about our latest oncology model, which cancers, for example, may have a disparate impact on underserved beneficiaries. How can they be part of the focus of our new models? The evaluation, even though it comes at the end of the model, we like to need to think about that early on, designing the proper evaluation. So we're asking the right questions that will allow us to get the right data. So at the end of the 5 or longer model period, we'll be able to assess the impact on health equity. Recruitment and rulemaking, that does get into how are we reaching out to safety net providers or organizations, for example, to encourage them to apply to our models. What is the engagement? What is the input that we need to have early on? Application, we always like to laugh a bit. Not all of our partners, particularly those that are new to value-based care, will be able to wade through hundreds of pages of applications and NOFOs and agreements and whatnot. And so what is the assistance that we can provide through the application process to help safety net providers and others with lesser resources to make their way successfully through the application process? And also, what can we add in the application process to signal that we value those with expertise and experience in taking care of underserved populations? Implementation and evaluation is fairly straightforward, but we are trying to, again, not drop our efforts when the model is finally launched, but how can we be helpful throughout? And scalability is just so critical. We have found, even for our models that have had successful outcomes, some of the lessons learned haven't been disseminated or adopted to the extent that we would like. And so we're trying to be more mindful about that as well. I would note that just 1 year after we announced our new strategy refresh, we did release these metrics by which we will hold ourselves accountable. We have metrics across all of the pillars, but for health equity, I included a slide with that. You can see some of the metrics here. For example, how many of our models are collecting socio-demographic data collection and health-related social needs data when possible? How have we been able to increase the number of safety net providers and safety net institutions participating in our models? We have clinical metrics that are actually looking at the rate as well as how well we've been able to close the gap. How well have we been able to reduce disparities in some cases? So we think that if we're able to track these metrics over the next 10 years, that will give us the information on how well we're doing, what are some of the areas that we need to strengthen our efforts, and provide transparency too to those outside in terms of how well we are performing. So now I want to turn to a few model initiatives, and initiative highlights. I would have to say, in terms of health equity, certainly I would say probably our Vanguard model was the Accountable Health Communities model that wrapped up last year. And that was the first model where we tried to systematically screen our beneficiaries for health-related social needs, refer them to social service organizations, and help them navigate the social service sector's community-based organizations to have their social needs addressed. And certainly when this was announced in 2016 and launched in 2017, At that time, it was a huge deal to have CMS and not Medicaid, but more on the Medicare side, including the Medicare side, to really invest in thinking through how can we help address the needs of our beneficiaries more holistically, to include their social needs. Now it's kind of almost expected a little bit. It's no longer as eye-popping as it was in 2016, and we're quite excited to see that we have been able to help shift some of the culture and the narrative in terms of how we need to think about our patients from the CMS Innovation Center. We were also surprised at the model at the level of need that was identified, certainly that surprised a number of our providers as well. And I would also like to note that even though the full evaluation is forthcoming, we were able to find that we were able to reduce use of the emergency department by 9% in the interim evaluation, which was significant. Building on what we learned in our Accountable Health Communities model, we have launched or modified several models over the last year that have incorporated different pieces of our equity strategy. I would note, start with our MA plan, Medicare Advantage Value-Based Insurance Design Model. As some of you may know, MA plans were granted special authorities by the Congress to screen and provide specific benefits to their beneficiaries with chronic illness. We built upon that authority by allowing the MA plans to target beneficiaries, to screen and target beneficiaries with social needs and provide them with additional supplemental benefits, which could be different rewards, gift cards, other help, financial help. And so we have been quite cheered about the uptake of this authority through our VBID model. And we are now starting to collect information about how the MA plans use this, have used this authority, what benefits have been provided, what has the uptake been by beneficiaries. So we're certainly continuing to learn more as we're investing more in these areas. Another new model that was announced last year and just launched in July of this year was our latest ACO, the ACO Realizing Equity, Access, and Community Health, or ACO REACH model. And this really laid out a number of equity provisions, a few of which are mentioned here. One that we realized, again, that providers taking care of a disproportionate number of underserved beneficiaries will require additional resources to provide comprehensive care. And in this model, we are testing a different health equity benchmark adjustment, which will result in those taking care of the highest number of disproportionate, the highest number of underserved beneficiaries, additional funding. And we define underserved beneficiaries in this model as a composite measure of those living in deprived areas as measured by the Area Deprivation Index, and those that are duly eligible for Medicare and Medicaid. We are also requiring participants to prepare and submit to us a health equity plan. We think that health equity plans are a way to ensure that our participants know their population, work to identify any disparities, and develop interventions to address any disparities. And that is the area where we want them to share their progress with us as well over time. In this model, they will be required to collect socio-demographic data, and to the extent that they can, health-related social needs data as well. So a number of these and other provisions as part of the ACO REACH model. Again, it just launched in January, but we're already pretty excited about what we have learned in terms of the intentions by the participants in addressing health equity. Enhancing oncology model, I mentioned that briefly, and that this too has a number of health equity provisions that were announced last year in July when the Enhancing Oncology Model EOM was announced. It will launch in July of this year. If all goes well through the final clearance processes. Some of the health equity components of this model, it too will require socio-demographic data collection reporting. It will require screening for health-related social needs. It too provides a risk-adjusted benchmark and an enhanced payment for providers taking care of high numbers of underserved beneficiaries in this model, defined as those who are duly eligible for Medicare and Medicaid. And two, the EOM participants will have to prepare and share with us a health equity plan. Now, moving to primary care first, we certainly have signaled publicly that we are working on another primary care model. We have launched 3 models to date: comprehensive primary care, comprehensive primary care plus, and now primary care first is in the field. Primary care first is comprised mostly of experienced practices, experienced in value-based care arrangements. And our primary care model that we're working on now is certainly will include those that are experienced, but we're also trying to reach those who are new to the fold, those that have less experience in value-based care, including safety net providers. Working with our colleagues in the Health Resources and Services Administration is part of the effort. But why I want to mention primary care first is I think it provides an excellent example of how our attention to equity in the models does not stop when the model launches, nor does it stop until we get the final evaluation. We're trying to look early to see if there's any issues that may need to be addressed. And in primary care first, I'll show this heat map as one example. We looked in the Los Angeles area to see if we could see where are the participants, where are they located in the Los Angeles area. And if you look at the maroon dots, you'll see that that is where most of the Latinx communities are located. And if you look at the open dots with the black borders, that's where our primary care participants are located. So you're able to see there's a bit of an imbalance between where underserved communities are and where our primary care participants are located. And so for us, this is, again, early on, we're well before the evaluation period, certainly. But for us, the question is, why is there this imbalance? Are there fewer Medicare beneficiaries in these areas? Are there fewer providers in these areas? Or is there something about the model design that disincentivizes those in the Latinx communities from participating? These are all questions we're trying to sort through now. But again, it's critical for us to see these issues, potential issues early on, so that we know if there needs to be any modifications or adjustments made, whether to this model or our next primary care model. And of course, certainly some thought, well, in the Los Angeles area, is this an outlier? But we did a very similar analysis in Detroit. And in this case, where the pink dots are, or Black communities are in the Detroit area. And again, you'll see the open dots are where our primary care first model participants are, in the same imbalance. And so the same types of questions are being asked internally to see, again, what we can learn, if there's anything we need to be doing differently on our end with our model designs, to make sure, again, that we're serving all of our beneficiaries. All of the beneficiaries have the opportunity to receive some of the benefits from being part of our models. And I think as part of this is we're trying to think through with that life cycle approach. We are looking at implicit bias. Are we baking that into our models inadvertently? We did a pilot study over a year ago at this point to see if there were any design, if there was any decisions or policies that we adopted that could potentially lead to bias, and with a focus on 3 different models. And we did find there are certain decision points, how we paid, how we decide who is eligible, that could have restricted eligibility for some of our diverse beneficiaries. And so we're trying to be more intentional about looking for implicit bias early on in our models moving forward. So just briefly, in terms of administration priorities, just other areas that we are targeting that also certainly have implications for equity. Maternal health is is a major priority, both for our administrator, Chiquita Brooks LaShore, but also for this administration, as you know, and we are across CMS looking to see how can we improve maternal care and reduce the disparities in maternal health outcomes for both moms and their infants. Seniors, we have also signaled publicly that we're interested in thinking through how can we improve care for those with dementia. And so that's another area that I expect more information will be coming out in the coming months. And I had already mentioned primary care. I realize some of these pictures, they could apply to many different ones, but primary care in the bottom is an investment, as I mentioned. And at the top, behavioral health is just a key priority also for CMS, also for this administration. We have shared that we are starting to think through what are the different ways that we can embed behavioral health throughout our models generally, as well as potentially a standalone model to improve care for those with serious mental illness. There are other, these are not all of the different priorities that we're working on, but I thought sometimes it's helpful to know some of the priorities that are being actively worked on right now. And so with that, I'm going to stop, and I'm going to stop sharing my screen. Here is my email information. Certainly, if anyone has follow-up information or would like to meet with me or the team, we do encourage you to reach out because we always find the meetings to be very helpful and providing guidance or feedback on some of our work. So please do reach out. So I'm going to stop sharing my screen, and I will turn the mic back over to you, Alicia.
Wonderful. And I have a couple questions that just came in. So maybe we could ask those, Dr. Hughes, and then we can move on to the other group. One, a lot of our members do a lot of behavioral health work. And so there was a couple of private messages to me just to ask if you could maybe dive into that a little bit deeper and the role. You know, a lot of our members are Medicaid certified and those kind of things, but kind of how yours, what the landscape looks like for behavioral health.
Sure. So there's a number of different ways. First, I would like to point out that the White House, they've released a mental health, mental health plan, and the Department of Health and Human Services has also released a roadmap to behavioral health. There's a formal fancy title, but we call it the roadmap very loosely ourselves. And as part of that, the Department of Health and Human Services also convenes a Behavioral Health Coordinating Council, the BHCC. And that's a way for all of the agencies to come together through 5 different subcommittees to really think through how are we maximally leveraging our own individual authorities and resources, but also how are we cross-fertilizing? Like what can we at SAMHSA learn from CMS, and what can it's really generally more the reverse. What we at CMS can learn from SAMHSA, or what's happening with our colleagues at HRSA, if we think about behavioral health workforce, for example, or some of thinking through some of the block grant funding that's available, or parity enforcement. There's a lot of activity at HHS. I don't know that I could name all the 5 committees. I know one is focusing on children and youth, another one's focusing on suicide, opioid use. We are focusing on behavioral health integration. And I think for us, that's especially key, especially given the workforce challenges. How can we better embed behavioral health in primary care, or primary care and behavioral health? And I think there's a lot of different issues within that we certainly are working through for my subcommittee. And I would say for CMS, behavioral health is also one of our 12 cross-cutting initiatives. And so that opportunity for all of the centers, Medicare, our colleagues in the Centers for Clinical Standards and Quality as they think about the measures, our colleagues of Medicaid, our colleagues in the marketplace, the Office of Minority Health, for us to think through what is our strategy in the behavioral health space. Some of our strategy has been discussed and will be discussed at our annual quality conference, which will be the first week of May this year, and is virtual and open for everyone. But we are very much thinking, again, what are the opportunities to address behavioral health as a standalone model? What might we think about there? But also, how can we embed it in whether our primary care models, our state-based models, our maternity models, what are all the various opportunities to do more there, just given the scale of the need.
Thank you. And one last little one, and then we'll turn to Lindsey. Is any insight? The majority of our members on the Zoom here really address those social determinant of health, those non-medical services and supports that are known to improve health equity and health outcomes. And so from your vantage, what are you seeing are the most important outcomes to measure that the role of, addressing social determinant of health in health outcomes?
So that's a very interesting question. Mm-hmm. I'm not sure that here at the CMS Innovation Center, we're necessarily measuring the best, in part because we are measuring what we have to by statute. And so for us, there's always expectations for our models that we will improve quality or reduce costs. And so that's why, for example, in our accountable health communities model, we looked at emergency department utilization, because we know that there's quality issues, but there's certainly, especially your cost issues. And is that a way to, is that an adequate measure there? We are very much aligned, looking to our colleagues in the Center for Clinical Standards and Quality. They are looking at drivers of health, social drivers of health, as a measure for our Medicare programs. And that is key, because how well we screen for SDOH, how well providers screen for SDOH will then therefore be linked to payment down the line. And so I always think that is really helpful to note. We are also certainly tracking our colleagues in Medicaid and the waiver authorities that they're providing that can allow potentially additional funding to be provided. But so not only going back to the more directly what you asked, and so certainly healthcare utilization, we are also focusing a lot more on patient experience, our beneficiary experience, and we think that in the SDOH space is certainly relevant as well. And I think well, I guess I'll stop there because I know I can go on at length.
That was very helpful, though. Thank you. That was wonderful. So before I introduce, let's see, I'm checking the chat. Okay, any other questions before we bring in Lindsey and Donna, who will join in the conversation? So first of all, thank you very much, Dr. Hughes, for your insightful presentation, and it really helped give us the lay of the land and how you all are really driving moving forward population health. And now I'd like to introduce two of our member speakers. So we have Lindsey Sand, who is Vice President of Population Health at Knute Nelson in Minnesota, and Donna Magnuson, Chief Program Officer of Lutheran Family Services, who's mostly present in Nebraska. And they will be sharing their innovative solutions and partnerships to advance health equity in partnership with healthcare in underserved and rural communities of Nebraska and Minnesota. Lindsey, would you like to start us off?
You betcha.
Well said.
All right. You can go to the next slide here. So yes, as Alicia said, I am from Knute Nelson. We are a senior care continuum provider that services West and Central Minnesota. We are currently in 43 counties, of which almost all of them are rural counties. So we provide anywhere from wellness and outpatient therapy all the way through the nursing home, independent living, assisted living care to home health, hospice within the community. Our home and community-based services are by and large our largest service lines, with about 85% of what we do in our care environment. Our mission is to enrich the lives of everyone we serve. And within the last 3 years, our organization has done a lot of investment in really digging in deep with strategic planning and thinking about what is that next level of what we need to do to ensure that our elders, our seniors living within our rural communities have the supports and healthcare necessary in order for them to continue to thrive living within their communities of choice. And so we've done a lot of investment in population health and in relationship building with our health plans, as well as our healthcare partners and community-based partners within our region. We can go to the next slide. So I'm going to talk a little bit, I don't have a ton of time, so a little bit about our strategy and our thought process, and then talk about one of our programs that we've focused on building. So Knute Nelson has embarked on building out a population health service organization to work alongside our current service lines. This organization is really built to complement the work that's already being done within our communities, as well as kind of help to steer the ship and move us more in that value-based thinking. Our communities are very much still operating in a fee-for-service mind frame. And so we as a senior care organization, in knowing that quality needs to be the focus, want to steer that ship towards a value-based thought process. And so we wanted to create a model that allowed us to help to do that. And so our population health service organization is really about driving better care, lower costs, and engaging our workforce and really striving for better quality of life for our older adults within our community. We've done that through creating a care management and care coordination program, really working on market opportunities, identifying care gaps within our communities. We've applied for some rural health development dollars, our Connected Communities program, which I'll talk about, and working on some health plan partnerships that really will work towards some risk share to help support our efforts and hopefully help to support our current programming as well. Looking at iSNP as a way of helping to kind of invest into our housing, as a way of trialing out some theories about what we can do as a care management strategy, and some per member per month as a way of introducing thought process and theories, and really proving to our health plan partners that a different way can be done and that rural communities operate a little bit differently than our urban counterparts. Next slide. We also really focus on integrating and aligning. And so really starting to be thinking about it more enterprise thought process as to how we operate at Knute Nelson in integrating the philosophy of population health across our existing services and our workforce management. So how do we utilize technology? How do we ensure that our workforce is engaged in their interest and really working to their trained skill and interest level? Looking at ways of introducing psychosocial support in partnership with clinical care across the continuum of care and for our workforce, and introducing, again, those value-based approaches that are so important and so vital. You can go to the next slide. Our Connected Communities program is one of those initiatives, and we are so blessed with the support of our Minnesota Leading Age Minnesota Foundation, as well as UCare Minnesota for funding to help us with this initiative. These are our partners in this initiative, and they are local healthcare entities as well as community-based organizations. And we really do consider these all the safety net, and we all come together with organizational humility as well as dependence on one another to really ensure that the lives of those that are living within our communities continue to have their needs be met, and that we're all working towards some common goals for those living in our communities. Next slide. These are kind of our community goals that we've worked towards, again, really focusing on the well-being of our aging population, improving that whole person experience, reducing the costs of care, and overcoming that perceived barrier to rural care delivery. Next slide. We've done that through the introduction of a few things, really working on introducing a community care navigator. Truly understanding the resources available within the community is essential. And that includes anywhere from the really understanding what programming benefits come through a person's health plan, and ensuring they're tapping into all of the supplemental benefits that might be available, all the way through that local church volunteer that might be able to come out and help with some social isolation concerns that might be available to them. We introduce things like an age well care manager that could be a social care manager, a licensed social worker, or an RN care manager that can come out and help a person understand their clinical needs. We introduce telehealth monitoring, so vital care support monitoring, introduce the ability for them to talk to their care manager virtually, be able to talk to their physician virtually, be able to connect to family and engage through electronic mechanisms, and also be educated through a tablet, utilize a number of different mechanisms for wellness, virtual, you name it. They can utilize the platforms to do those things. And of course, personal emergency response systems that can alert their caregivers of choice, or if they don't have a caregiver of choice, emergency responders. Okay, next slide. And this is my contact information. I'm sure there is probably quite a bit of information that I have missed, but there are so many great opportunities, and as providers within our area, this is such a great time to be jumping in and utilizing the expertise of our industry to be making a huge impact. So I encourage everyone to make the leap and to live your mission. Thank you.
All right, and Donna, you want to share a bit about your work?
Sure. Good afternoon, everyone. I'm really pleased to be here today. I've spent the better part of my career thinking about client-centered services using strengths-based approaches and team-based care. So all of the words being used by Dr. Hughes and certainly our partners with Knute Nelson really resonate with me. So I'm very excited to be here. So Lutheran Family Services is, as Alicia said, primarily in Nebraska, but we also serve in the southwest corner of Iowa and are expanding our horizons in many ways as we speak. LFS is a very multifaceted organization in that we have two core competencies, one of which is health and wellness, the other of which is community-based services. So if you think about the two sides of the house, the health and wellness side is really more of our therapeutic side, our clinical side, where we are primarily providing services either to people in office or through telehealth. Telehealth for LFS grew exponentially during the pandemic, and we have been able to really think about how do we best serve people across Nebraska. It has allowed us to expand across much of our rural communities because people have better access now through telehealth. Of course, we also provide some of that unit service in the field, and I'll talk a little bit more about that through things like our CCBHC, Certified Community Behavioral Health Centers. On our community-based services side, that's really more where we think about our forward-facing, more of the direct service case management piece, where we're often in the field, in the community, while also doing some things in office. On community-based services, we are providing a lot of children's services, kinship care, family preservation, family care and support of families with young children. And in addition to that, we also have a very robust refugee and immigration program. I bring these things up because it really helps explain where we're going in terms of our value-based care contract and what we've learned along the way. We serve populations of children, adults, families with particular focus on military and veteran services, senior care, as well as those with limited English proficiency. Next slide, please. So today I wanted to talk a little bit about our value-based care contract. The conversations with Optum started back in 2021, really looking at that quadruple aim of improving clinical services and quality, client outcomes and experience, as well as improved provider experience, all while reducing health costs. We put a lot of time and effort into the last year of working with our value-based partner to really think about how do we best serve these clients, high cost clients, referrals directly from Optum of up to 400 to 800. Looking at, of course, at the per member per month, but where a lot of our attention has been is really about how do we ensure that we are engaging people in a way that see what we're doing as new and different, as a way to improve their lifestyles, their health, while also meeting all the required measurements. So next slide, please. So I want to talk a little bit about, how did we get there and why did we feel we were ready for a value-based contract? And a lot of that has really been based on our work with the Certified Community Behavioral Health Center, where we've learned a lot more about data tracking, looking at prevention rather than intervention, and really rolling up into our care and service coordination model. When I talk about that, in most environments, you would hear people talk about care coordination. What we've learned along the way is that in order to integrate our entire organization, we had to add the word service so that it wasn't just focused on our health side, but really looking at things along the social determinants of health and really thinking about it through the lens of the services we provide in a care coordinated way. So a lot of work has been done there. The other piece of that has really been allowing us to look at the staffing. At a time of staffing shortage, we also needed to be thinking about how do we bring staff in a value-based way that were best at the job in the beginning. And so really thinking about who was going to be best at thinking about care and service coordination. And so we actually started with a staff person who had been with us for a number of years, who was looking at community support services in our behavioral health program, but also realizing that as we staffed up, we really also needed to think not only of what skills people were bringing to the organization, but also what types of training. So some of the things that we've really focused on there have been related to making sure LFS is first and foremost a trauma-informed organization. So really looking at trauma-informed care so that we could be building service plans for people that really had them at the heart of the matter. In addition to that, we provide mental health first aid training, which we think has been absolutely helpful for staff, all staff in the organization, whether you are a therapist or a front desk staff person, to have that mental health first aid component so we can be better equipped to serve people in that way. Another piece that we've had to add because of value-based and because of the care and service coordination model has really been thinking about how do we engage clients from the front desk on up. So we even have changed the titles of people at the front desk to client engagement specialists, because we realized that they were really doing a lot of the heavy lifting when it came to intake. And so really thinking about them in a different way has been very helpful in continuing toward our integration model related to population health. All of this while focusing on value-based outcomes, focusing on per member per month, focusing on making sure that when we were engaging with the clients being referred to us, that we were providing them a new and different way for them to look at their own lives and know that we were there to help in a coordinated manner. Next slide, please. So now we're really looking at, as an organization, what does interagency collaboration look like? There's been a lot of conversation on this call about the importance of partnerships. We at LFS believe that we work pretty well with partners, but what we discovered along the way, being a multifaceted organization, we really needed to turn internally and look at how do we see ourselves as our own best referral system and our own best expert on those external network resources as well. And so we've really looked at things along the social determinants of health. And I want to talk about just one example to give you a sense of where we're going. And so through value-based care, we are, of course, looking at the HEDIS measures. We're looking at all the requirements of the grant. But we also wanted to think about, so what do we have to offer the members who are coming to us for help? And so one example would be those kinship families who maybe are on Medicaid, maybe are using Medicare as a grandma now caring for youth. And in past, we would have looked at things through the behavioral health and health lens, but by focusing on care and service coordination and the social determinants of health, we've now been able to begin to tie people right into our kinship care programs or our post-adoption programs. With the refugee and immigration program, of course, we're always thinking about what services are available there when now people with limited English are also accessing the health and wellness side of the house. So we're spending a lot of time really on written processes and procedures. We want to make sure that this is sustainable in the long haul. We want to make no assumptions about what we were doing before in terms of referral and making sure that we are doing that now across the organization and across the state of Nebraska and beyond. We really want to look at connecting the dots across all services. This to us is what care and service coordination really means, as well as certainly talked about on this call, the importance of data tracking and making sure we're measuring along the way. Of course, in doing so, we also need to make sure that we are recognizing and recording our network partners. No organization can be all things to all people, but we hope to be able to connect all people to all things. And so we're really looking there also at making sure that we have written policies, looking at strengths-based approach, who really in our partnership network, including ourselves, is best at this piece of work, and how can we make sure that people are connecting in a way that has value and importance. This integration care model is really helping us culminate all of our available services into one big ball, so to speak, in terms of making sure that we are using ourselves. We really think it's important to have clear roles and responsibilities, using a strengths-based approach, knowing that all staff cannot be good at all things or know all things, but through strengths-based lens, we can really ensure that we are getting the best people in front of those that we are trying to serve. All of this while making sure that the client is the center of wherever we're going. Really focusing on a couple of things and making sure that there is client voice and choice in mind, and that we're always looking at constant improvement. All of this has come out of CCBHC, and now most importantly, looking at things through value-based care. Value-based care has certainly allowed us to look at it through a more financial lens as well as the integrated lens. Going on to the next slide, please. So in a next step kind of way through an integrated approach, first of all, we think that it's not how you ask the question, it's not what questions you ask, but rather how you ask it. I saw a quote the other day while perusing population health on the Veterans website that talks about it's what matters to you, not what is the matter with you. So we are really thinking about that as we begin to look at our various tools that we use to assess people. We have HEDIS measures. We have the NOMS data for CCBHC. We have the daily living skills of DLA 20. We use a social determinant of health survey called WellRx, while also looking at the other models that are out there. Looking at self-sufficiency matrix, all of which looking at how are we measuring and really looking at the impact we're making along the social determinants of health. All of these tools are very strong tools, but we now are asking ourselves the question of how many times are we asking the people the same question, and how can we do a better job of that? And so I think for now, we'll add there, our value-based care model has certainly allowed us to think even more deeply about the population health and thinking about care for those we serve. And we just continue to grow and learn through this process. So thank you for your time today, and I hope you found this useful.
Wonderful. Thank you, Donna and Lindsey and Dr. Hughes. We've got about 5 minutes for questions. Any questions for? Looks like Dr. Hughes has one. Wonderful.
Well, Actually, I do have
Or
questions,
comment.
but I did see one directed to me in the chat, so I thought
Oh,
I
okay,
would
good.
mention that one. It's about the chart model, whether there could ever be a rural ACO. I will say that through the chart model or community health access and rural transformation model, we recently learned, as you may already know, that none of the hospitals in the states in the chart models, they were not able to get any hospitals to sign up. As you know, rural hospitals are struggling in many cases, and our timing was certainly exquisite right before the pandemic hit. So now we're trying to think through, though, based on what we did learn through chart, even in the absence of hospitals signing up, what is our path forward for rural health? I don't know if that will turn out to be a rural ACO, a rural focused ACO, but the team that has been leading our rural health efforts are starting to kind of go back to basics and think through what is it that we can do. And I expect over probably early summer that we might be in a position to share more ideas and possibilities for us kind of moving forward. So I was one, but I was really curious, even starting with Lindsey, you mentioned I would love to know your experience with risk sharing. I think you mentioned upside, downside. How was that part? How was that perceived, and what was the feedback that you heard as you're implementing that?
We are still really in open talks with them. So we have spent the last couple of years in conversation with health plans and beginning to demonstrate through our pilot project that collective work and really how we rally the community and how we pull together our partners is the way that we have to do it in our rural communities in order for impact to happen. And there are certain approaches that work in rural communities that work better than in our more metro partners. So we have begun to have conversation. We've begun to have conversation for 2024, and our health plan partners are actually really excited to be having these conversations with us, simply because it's a unique path for them. They've also mentioned to them that, to us, that they sometimes struggled with figuring out what's the best path for rural communities and what's the best approach to take. And so, we think that we've got a great answer to it. And, we truly believe that senior care entities have a great solution to value-based care. And so we might be your solution to the rural ACO problem, Dr. Dora Hughes. So you give me a call, we'll help you.
Certainly will be, absolutely we will. I definitely want to learn more, but I don't want to monopolize our last few minutes. So
Wonderful. Any other questions? Well, I want to thank all three of you so much for this conversation and really sharing both the vision and the broader CMS strategy for health equity, as well as the ways that Donna and Lindsey and their organizations are really testing and implementing these ideas on the ground. So thank you everyone for your participation, and we have you'll be receiving a follow-up email from Kim that will have materials from this webinar, including the recording and a link to additional information from CMS, as well as contact information. We'll look forward to seeing you at the next Strength and Service series, and I hope you all have a wonderful rest of the afternoon. Take care.
thank you.